Hello, and welcome to today's webinar, Implementing Artificial Intelligence in Healthcare, Lessons Learned from Innovators and Early Adopters. My name is Christine Quinn, and I'm the Director of Strategic Initiatives at the Canadian Foundation for Healthcare Improvement, which has now amalgamated with the Canadian Patient Safety Institute to achieve safer, higher quality, and more coordinated patient-partnered care. And we look forward to introducing our new organization to you in the coming months. I'm also joining you from my home office here in Peterborough. You can tell by my background, the lift locks behind me, and I respectfully acknowledge that I'm joining you today from the traditional territory of the Mississauga, Anishinaabe. And I would like to offer my gratitude to our First Nations for their teachings, and may we honor those teachings today. So, a couple of housekeeping items before we begin. First, we are pleased to offer today's presentation with simultaneous interpretation. So to listen to the audio in your preferred language, please follow the instructions that are in the chat. Second, we do encourage you to use the live chat box and add your comments and use the Q&A chat box or the Q&A pods, to pose your questions throughout the webinar. You can also share your thoughts, experiences, your relevant resources related to today's topic on social media using the hashtag AI-driven health. We've got an information-rich webinar for you today. I'm really super excited about our panelists. So please type in any of your own reflections and comments, and our speakers will really try to get to all of your questions during the Q&A period. But if we do run out of time, we are committed to answering those questions to you offline, and we'll get those responses back to you. So next slide, Sheena. So today, we will be exploring the implementation of AI through the lived experience and lessons learned. We're going to identify some enablers and challenges and uncover some of those necessary elements and pathways for successful implementation. Next slide, thanks. So I'm really pleased to introduce our moderator today for today's discussion, Dr. Alison Paprisa. She's the Executive Director and Affiliate Scientist at ICES and a member of the Executive for Health Data Research Network Canada. She's a former CFHI Extra Fellow, and her previous roles include being the inaugural Vice President of Health Strategy and Partnerships at the Vector Institute for Artificial Intelligence, for which she's developed and implemented their health AI strategy, along with being the former Director of Strategic Partnerships at ICES and the Director of the Planning, Research and Analysis Branch at the Ontario Ministry of Health. Dr. Paprisa was a member of the Royal College of Physician and Surgeons Task Force on AI and Emerging Digital Technologies, and the Canadian Institute for Advanced Research AI for Health Task Force. Welcome, Dr. Paprisa. Next, I'd like to introduce Dr. Gerald Battist. He's a clinician scientist trained in medical oncology and molecular pharmacology. His focus is on therapeutic resistance. He's the director of the McGill Center for Translational Research in Cancer and the director of the Segal Cancer Center at the Jewish General Hospital and the former chair of the McGill University Department of Oncology. In 2014, he co-led a successful application to establish the Canadian National Center of Excellence in Personalized Medicine. And in 2016, Dr. Battist was appointed member of the Order of Canada and the Knight of the National Order of Quebec. Welcome, Dr. Battist. And I'm very pleased to welcome back Dr. Alexandra Greenhill. She is one of Canada's leading physicians in digital health innovation and the recipient of the Canadian Medical Association's Jewel Innovation Award. After over 15 years in director and leadership roles, Dr. Greenhill currently serves on CIHI's board, is the chair of the Board of Physician Innovators Canada and Global, and is currently the CEO and Chief Medical Officer of CareTeam Technologies, a next-generation virtual care collaboration platform enabling health organizations to do care coordination and communication across different settings. Welcome back, Dr. Greenhill. And our last panel member, Dr. Kendall Ho, is an emergency physician in Vancouver Coastal Health Authority and a professor at the UBC Faculty of Medicine. He is the real-time virtual support pillar in the BC Emergency Medicine Network. He's the medical director of the HealthLink BC Emergency Eye Doctors in Assistance Service and works with the BC Ministry of Health and associated networks on organizing and evaluating virtual care services in BC. Dr. Ho also conducts digital health research on the innovative use of computers, smartphones, sensors, and wearables, and health data analytics in support of health service delivery for citizens and patients to achieve optimal health and wellness. So welcome to all of our panel members and our moderator. I'm going to hand it over to you now, Dr. Paprisa, to share your reflections on the progression and current state of AI in Canada's health sector, and as a primer ahead of our three speakers' presentations exploring lessons learned. Over to you. Thank you.
Thank you very much, Christine. It's a pleasure to be here today. We'll move to the next slide. Just say a little bit about how I come to this topic and why I think it's so important. And to do that, I'm going to put up this triad for data-intensive research and innovation, including but not limited to AI. And the source here is Graham Taylor, who's a faculty member at the Vector Institute. And this is something he shared with me, I think literally on my first day on the job. And he said, you know, Allison, if you want to get AI right, it's about aligning the objective or the task with the data that you've got available and the method or the model. And the reason I chose this particular triad to kick things off is that I think many of us, and I include myself in this, in the CFHI and quality improvement in health space, are very familiar with the top 2 points, that given certain data, there are certain questions that can be asked, certain knowledge that can be gleaned. But what's exciting about AI is we can now, in addition to using traditional statistical methods, and sometimes they're absolutely the right thing to use, we can bring in new methods and models to do new things with data that open up the possibility of new objectives and tasks. And there's a lot that can be done with AI. And I think that explains some of the excitement. It can be, in some cases, something like an efficiency. You know, a lot of the data that we have in healthcare, we don't have it because we wanted data. We have it because we didn't want paper processes, and the data is like a exhaust coming off a car. And with AI in real time, we can harness that data and we can do sophisticated things with it that, for example, improve efficiency. You know, we've got really smart scheduling systems in other sectors of society. We could bring those to hospital ORs, for example. AI can also be used to improve the effectiveness of interventions and personalize them. And an example, just to make it real, that really inspired me was at Holland Bloorview. They had it was like a game to help children who were doing rehabilitation on their shoulders, and their whole arm would turn into a laser beam and they'd shoot rockets out of the sky. And what they were able to do with AI is not just have this be a sort of set program, they would monitor when the kids miss the most and give them more exercises to build muscle in that direction. So a real cool application of AI. And then I think potentially the most exciting thing that AI can bring to this triad is the possibility of identifying new patterns that wouldn't even be humanly possible. So a good example of this is AI being used in a pediatric ICU to detect cardiac arrest 5 minutes sooner than any human could, taking all the data that are there and picking up on signals that human couldn't, and coming up with, you know, life-saving warnings in some cases. So this is great. I really like this triad. I hope you do too. But next slide. But the thing about the triad is it's just the beginning. So this is a publication in Nature led by Anna Goldenberg out of Sick Kids, and also Associate Director of Research Health at the Vector Institute. And if we think about the triad in the context of all the things that need to happen, it really brings us maybe to step 2 out of the 7 steps that are presented on this graphic, which I'll invite people to look at after the webinar. Because just proving something's possible is definitely not the same as implementing at scale. And another thing about this figure is the little stick figures are meant to be representative. While you might have a relatively small number of people, you still need a team to get that triad covered. The number of people involved and the work involved really grows as you move from something that's promising in early stage research setting to something that's actually implemented and maintained. Next slide, please. And this is what prompted us to hold what we called the Vector Sick Kids Health AI Deployment Symposium back in 2019. The report for the symposium is available on the Vector website, but I've summarized here 3 key themes interrelated that came up over and over again as we invited speakers from primarily North America to talk about actual AI implementation. The first is anything you introduce with AI comes into an existing context. It doesn't come into a blank slate. There's going to be existing data, existing tools, et cetera, and whatever you're introducing has to sort of fit in and respect that. The second is this idea of life cycle planning, really having people realize that there's a big difference between proving that triad works in a research setting, implementing it, and maintaining it. And the final one, and these are all important and interconnected, but I think maybe the most important one from my perspective is that every successful implementation, and not all of them were successful, but every successful one had deep involvement of multiple stakeholders. Moving to the next slide. The Nature paper gives us a summary of just some of the stakeholders that need to be involved. And I think this is also an indication of the complexity of it. You know, all of these perspectives have to come together and all of their knowledge and experience if we're going to have successful AI implementation. So this is not a simple thing to do. This is definitely in the complex space, in the true space of the world. So moving then to the last slide I've got, the importance of events like this. You know, getting the data prepared and developing AI models that are proven to work in a research setting, that's the relatively easy part. Not to dismiss it at all, but compared to implementation, you know, it's just the start. If we're going to get to successful implementation and ongoing operation of AI, there's much more work that needs to be done across multiple stakeholder groups. And in practice, the utility and effectiveness of the AI models depends on so many things, from the sort of very basic and mundane, like do you collect data live or does someone enter it after, to things like trust and interpersonal relationships and institutional culture, that if we're going to get it right, it's essential that we learn from each other. And that's my last point here, that events such as this, where we can learn from people that are doing it and they can share their experience so that we can build upon it as opposed to everyone starting from square one. I think that they're just critically important. There are benefits to be realized from health AI. We want them to be realized, and events like this can be a big contribution. So that's it for my introductory remarks, and it's my pleasure now to introduce Dr. Alexandra Greenhill, and she is going to, it's Gerald Battist I have next, with apologies. And Gerald's going to speak about use and implementation of AI across a range of topics where he works at the Jewish General Hospital. I'll turn it over.
Well, thank you very much, Alison. Thank you very much. It's really a pleasure to be with all of you today and to talk about this very exciting and emerging technology, which was largely developing outside of the clinical context. And now we're very much bringing it into the clinical context where it's finding its use. So there's much of it in use, but even more of it in kind of test use. I think we're all starting to think more about use-based development, the major modifications that the technology goes through once it's in the clinical setting. I think that there's a reason why this is kind of hitting the surface now much more brilliantly, and that is precisely because of the pandemic context, which has revealed, in fact, that best practice is very dynamic. And because of the remarkable information sharing that's gone on just in the context of caring for COVID patients, we're seeing a more rapid transformation of care and care practices and what we define as best practice than I think we've ever seen before. And I think that's a kind of a model of how we're implementing and using AI. We're implementing it and then refining it. I'm going to describe a few examples of how we've been implementing and using it in our center and centers here in Quebec. First, just in the COVID context, just two different ends of a spectrum or different parts of the COVID context. First is modeling at an institutional level, which has actually been taken up by the ministry to model, of course, case incidents, changes over time, but then to link that to inventory for PPE and beds, and of course staffing, and to be able to project and then even model the implications for what is really emerging as a big problem, and that is the care of non-COVID patients, in particular, to my mind, the cancer patients. And then at the same time, we're using it as a diagnostic, and we've been, since March, April, testing an AI-based technology that turns your smartphone into a sensor, a thermal sensor, and imaging a person's face will give you, it is proposed, some idea of their oxygen saturation. So it's not a wearable, but a remote sensor that can easily transmit information. In the cancer context, there's a whole range of uses of AI, and I'll just go through them just to give you the breadth of what we're doing, but I think what is possible. Firstly, the challenge of electronic health records remains a problem in cost and in implementation as well, and mostly in practice changing and change management, changing old dogs practices. And we're using a technology in which the patient actually is driving the development of their record into something that's electronic and transmissible through a natural language reading process in an app. And AI then looks at, they just upload parts of their medical file. The app looks at it and using AI sees what's missing and interrogates the patient to add additional information. And it can then build a trajectory and empower the patient to have an understanding of where the disease is going, and gives them an idea of the questions that they're likely to face and the challenges they're likely to face. It also uses AI to build a community by finding other patients in this community of practice using this particular patient-based app to find patients with the same diagnosis and the same stage, maybe even patients getting the same treatment, so that people really are sharing information starting at the same place. It also, and very importantly, helps us in a very dynamic way communicate with the patients. We have very startling data 2 years ago that demonstrated if patients can communicate new symptoms in between visits in real time, not waiting until the next doctor's appointment, and there is a human structure in place to respond to these symptoms, you can actually have an impact on human survival. And the overall survival of the patients, and the overall survival, at least in this one study of several hundred patients with metastatic cancer, was significant, and significant enough to match some of the recent survival benefits of some of the newer, most exciting immunotherapy agents. So having a dynamic, interactive communication with patients where patient-reported outcomes, PROs, can be communicated in real time and responded to is another part of this use of this technology. And then, of course, being able to link or match patients, as we say, with a different specific profile, both of their clinical situation, but also molecular profiling of their tumor to specific clinical trials or specific drugs. That's another AI feature with another app entirely that we're working on, and requires, as you can imagine, deep structured data. I'm just going to conclude, because I'm giving you a lot of information, that for all of these applications to work, of course, we need a human infrastructure in place to convert the AI product of the artificial intelligent analysis into best care. So for example, we're building an algorithm that cancer patients can use, or helps cancer patients, because a patient with a new symptom that's startling might be directed to some specific information, or might be directed to a psychosocial supporter, or to a peer, or to a nurse, or to a research nurse, or to a physician, or to an urgent care clinic, or to the emergency room. And we've been able to document a significant decrease in visits to the emergency room by using this kind of structure. But what we do need is to have each of those people at the end of the phone prepared to respond. And so you cannot, I think, optimally use AI without building the human infrastructure around it to convert it and its products into best care. Thank you very much. I'd be very happy to take your questions, and I've been noting that people are quite interested in the chat.
Thank you very much, Dr. Baptist. And I can't resist saying the alignment between your closing remarks and one of the recommendations in the AI task force of the Royal College of Physicians and Surgeons, which was really think of AI as a member of the team, right? This is a supplement to human capabilities, bringing in new potential, but absolutely, you know, the humans continue to be involved. Those are great examples, really exciting. Our next speaker is Dr. Alexandra Greenhill, and she's going to speak in particular about putting AI into action to support COVID-19 responses in communities. Welcome, Alexandra.
Thank you, Dr. Paprisa, and it's my pleasure to speak, especially after Dr. Baptiste. I was an occupational therapist and then a family doctor and emergency room doctor at the Jewish, and so I feel like, you know, I spent a significant portion of my life there, and it was the place where innovation thrived at the time, and I still see it is today. First, a quick disclaimer, part of sort of talking about AI is talking about projects we're involved in. And so I'm going to talk to you about one that we built through CareTeam. It's a company that I started and I still am majority shareholder of. And so with that disclaimer in place, please keep that in mind as I talk to you about what we're doing within CareTeam. And part of why a physician sort of moved away from the clinical and sort of policy space into building is I needed to build that reflected that workflow and need that we saw in the real life. And so if you go to the next slide, the core of what we had with CareTeam before COVID struck is the idea that in healthcare, everything is episodic and periodic and sort of responsive. And so if the patient doesn't show up with the next appointment, there isn't really a system to track that. And more importantly, as a patient is in the midst of an appointment, trying to take notes, there's lots of evidence showing that most of what is said is not remembered, or is not remembered correctly, and then it's not implemented. And so, you know, clinical observation was my patients would get better if at the end of the appointment they pulled out a notepad, or better yet, they had a binder of some kind where they would jot down the information, and they didn't show up alone, but they showed up with a loved one. And so in this hypothetical scenario, you have the patient in the middle, you know, the wife and the daughter who are involved in their care, and then the communication that's happening between all of them until we sort of implemented CareTeam was largely verbal or pamphlets, and we said, why can't we digitize that? And why can't we make it possible so that if the patient showed up at the appointment with his wife, but their adult daughter wanted to know what and how she can do to help, all of that could be shareable. And so on CareTeam, you can create a plan of action that the patient can implement, and then you can see what's happening between appointments, to the point that Dr. Baptiste made, and intervene and bring them back in, or remind them to do something, or give them a call, and make sure that what we know should be happening with the patient is actually happening. So if you go to the next slide, this sort of a CarePlan functionality works in health issues, but also works in social issues. And so working with immigrants, refugees, single mothers, just aging population at home, how do you track the different plan of actions different providers have, put them into a daily to-do list for the day, and make it possible to action that? And so obviously there's ways of using AI here to predict who is going to be likely to need a call based on a population of people and what have they needed until now. And you can do it on an individual patient level, or you can do it at a population-wide level. So in this case, George, how often does he call? Oh, he hasn't called in 2 weeks. It's something that pings and predicts that maybe you should give him a call and maybe he's struggling. Or if you have a new patient that fits the same sort of parameters as George, how can we identify that that person from the get-go is going to need more or less support than someone else? And so in the case of how this is applied, dementia is one of the use cases that we've applied this to. The other one that's interesting is preventing opioid addiction at the source. And it's a partnership with the superclusters here in Vancouver with several other companies, and identifying when the patient goes for surgery, what makes them more likely or less likely to become addicted to opioids, and how can we follow them up after surgery so they don't become addicted. Is the connection working better? I see some comments about it breaking up. Okay, thumbs up. So maybe next slide. Okay. Did I lose my connection here? This is where technology sometimes solves the issue. Okay, perfect. So if you go back one slide, actually, one of the things that we did when COVID struck is we said, okay, we have all of these patients who are isolated at home, who are high risk, vulnerable for various reasons. How can we use AI to scale the effort to support them? And we had a project that was funded by the federal government and Scale AI, where we collaborated with Fleet Ops. It's a company that does truck distribution, and they had an algorithm in place that essentially said if somebody needs something delivered, the algorithm matched the right type of truck to the delivery that people wanted to have. And so whether it's refrigerated, the size, how close it is it available for the whole time of where it's going to go? And so it was this sort of a sophisticated algorithm that's been used at scale to manage shipping. And through the project, we adapted that existing algorithm to the use case of I need to send a volunteer to give someone a ride, to drop off a meal, or to do something else related to a person who is at home and either is quarantining because they have COVID, or the opposite, they're trying to avoid going outside because they're at higher risk for COVID. And so if you go to the next slide, what this does now is it has the ability to identify people in your community who need support, identify what kind of support they have, use the existing CareTeam functionality to create like a bubble of friends, relatives, neighbors, and volunteers that are dedicated to that person, or use AI for that pooled volunteer function to be able to say, okay, we have 600 requests today for meal deliveries. We have 140 volunteers. How do we match the volunteer that's available for the request and make the entire experience seamless? And that's the kind of power that only AI can do, because scaling that on a human with an Excel spreadsheet and phone is just too complicated. And so the interesting lesson learned for all of that is we've had organizations who've embraced this and who've said, yes, this totally makes sense. And other ones, especially in the community, who are either not equipped with the basics. They literally don't have computers. The coordinator for the volunteers is missing the tech for a basic browser on the internet to be able to use this technology, but also a belief that AI somehow will take away the personal component, will make it anonymous, and will remove the connection between the community organization and those that it serves. And it's been really interesting that the only way we could undo that belief is to actually show examples of our successful users where a lot of the make work was taken away by the technology. So they no longer had to do a lot of calling and finding out who is available today to do deliveries, but all of that was automated. So they actually had more time to spend some time with the person who needs help. And they also implemented things like the volunteer may call somebody who does not have a laptop or smartphone and needs help. And so if it's an elderly person who doesn't have the equipment or doesn't have the know-how, you can dedicate a volunteer who does the calling about what kind of assistance they need. Then they put that into the system and that gets matched. And so it serves everyone in the community, regardless of their level of skill and technology knowledge, which is one of the big things in AI. We need to create the kind of solutions that don't create an army of people who can't access the services just because they're not technology savvy. And so hopefully this gives you a bit of a look, see how AI can assist in areas within health and social determinants of health. And I'm happy to take questions. Over to you, Dr. Paprisa.
Thank you so much, Dr. Greenhill. That's great, and a real great example of how foundational investments in data and AI can have benefits across many sectors. So our final speaker before we move to the group Q&A is Dr. Kendall Ho, and he's going to focus his presentation on AI and machine learning in emergency medicine. Over to you, Dr. Ho.
Great, thanks, Dr. Paprisa. It's an honor for me to be here. Thank you so much for inviting me. And also, I'm very, very glad to follow Dr. Battist and also Dr. Greenhill. I think they've given you a lot of excellent examples on a system basis and also on a community basis. And what I like to bring forth is, as an emergency doctor, how can we also leverage AI to support patient, especially when we think about the gap between acute care and community care. Often when patients cross gaps, that they can fall between the cracks. And so how can data and AI support that is the subject of what I'd like to explore with you with a few examples that we're currently doing. Next slide, please. First, I want to introduce you my son. He's very interested in investing in stocks. I'm absolutely a beginner on this. And so he was telling me that, the numbers tell the story. When you invest, don't just look at stock price. Look at for example, some ratios, price earning ratio. So you got to look at the spreadsheet of the company, compare that to the stock, and also you want to compare the other stocks in the same market, not only the general index, but also in that particular industry, compare for data. And so I think next slide, I'd like to reflect on that and say that, well, in fact, very often we collect a lot of data and also the opportunity for us to collect even more data. How can we leverage that not only to support our clinical care today, but use machine learning AI to really help us to look at those data and look at the signals in those data and help us better? I think Dr. Paprisa gave a really excellent example early on about a pediatric ICU looking at detection of signals 5 minutes before cardiac arrest. But I submit to you, there are many, many of those opportunities here. And here's one example. We were funded for a CIHR grant for 4 years and looking at using technology to support patients with heart failures when they go home from hospital. Ladies and gentlemen, if all of us have heart failure today and we're admitted to hospital, and upon discharge, 1 in 4 to 1 in 5 of us would need to be readmitted to hospital within 1 month. That's a huge implication in terms of the patient's autonomy, the management of illnesses, how they feel, and also the health system. And so in looking at that, what we did was we support patients when they go home to give them a group of technologies, oxygen sensors on the fingers, weight scale, blood pressure cuffs, and also a tablet, ask them how they feel. And so by doing so, we follow them after discharge from hospital to home, and then to see if 1, does it help our patients in better self-management? 2, does it help us as health professionals monitor them better? And 3, does it help the health system? And we found that in our pilot projects in 3 hospitals, we're able to reduce hospitalization by 59%, decreasing emergency department visit by 44%, decrease costs for patients and the health system by 33%, and the patient's own self feeling of wellness has significantly improved. And so we've just finished our randomized controlled trial of 21 communities, and we're now analyzing the data. But what I'd like to emphasize today is the data that we collect. And next slide, please. Now, this is a bit of a busy slide, but let me unpack that a little bit. If you look at the 5 graphs, the top one is about the weight. And so when the patient get discharged, the weight progressively decrease because we want to get rid of fluid in their bodies. And by doing so, weight is a very good indication. And then we look at the systolic and diastolic blood pressure, which is the second graph. We look at the third graph, which is the pulse, the heart rate, and then the fourth graph, which is the oxygen saturation. And then the final one is called shock index. It's dividing pulse by systolic blood pressure. And we use that for patient in shock, like for example, in trauma or cardiac arrest. That gives us an indication of severity. The higher that number, the higher the likelihood of patient sickness. We also collect patients' own feeling. For example, the blue square is about when the patient says, I'm quite weak and fatigued. The golden circle is when they visit the family doctors, and the red pentagram is when they have heart failure that needs emergency. I've picked out the point in time in this one patient where you can see that on that blue curve, whereas in general, the trend is that the weight is decreasing. But on that particular day, the weight was a little bit recalcitrant, not quite ready to go down. But then the systolic blood pressure on that day became quite unstable and went up. And the heart rate also has gone up. And then at the same time, the oxygen saturation is fluctuating. And finally, the shock index on that particular day peaked a bit. It's not surprising then, on that particular day, the patient felt fatigued. But if you look just a little bit down, there's a red dot next to it. And you can see that the shock index has gone up to 1. And that was the day that this patient visited emergency department. And so in looking at this data, it's not just about historically, we look at the patient and kind of synthesize the data in our brains. But if we can have AI, as we early talked about, as a member of our team, to be able to kind of sift out this type of data for that particular patient. And in fact, if you look at the whole population of patients with cardiac diseases or heart failure and do that, that would really increase our ability to say, well, maybe we should intervene before the patient go to emergency. In fact, even better, to intervene before the patient visits the family doctors and use Alexandra's system so that we can help the patients in decreasing the factors that she has. Next slide, please. And so we've been applying that. We've finished our heart failure model. We've done that also with a patient with a COPD or lung disease. And currently we have another grant, very fortunately, looking at hypertension management and also one on medication management so that we can layer on these type of different disease entities and also data on it. This is a study led by Professor Soy in Hong Kong, and I had the pleasure of working as a member to support. Looking at large databases, Sprint database is these days with a hypertension guideline. Sprint database really is a database of 8,000 patients with blood pressure problems. And in Hong Kong community, they also measure 1,000 patients with blood pressure. And what we did here was we look at people with blood pressure and we divide them historically into 4 equal parts or quartiles. Those with high blood pressure, those with medium high, medium, normal, and normal blood pressure. And we look at the top 25% quartile, and we found that there's quite a bit of blood pressure variation, meaning the high number and the low number varies a lot. And we found that when there's variations, that it can lead to higher risk of stroke or heart attacks. And so when we classically divide them into 25%, that there's a 33% variation of high blood pressure variability in that category. And so by just dividing that number, we can get a quarter, 1/3 of those patients that we need to screen and make sure that we don't get into problems. And so we apply a machine learning protocol in those 10,000 patients. And we found that when we do that, we actually can find the top 14%, as opposed to 33%, we cut that number in half, 14%. And in that 14%, we can do a lot more targeted screening and targeted therapy on that. And that comes back to Dr. Baptiste and also Alexandra's point in that AI can not only help us in therapy, but help us in selection of the right population when we screen. So that's another way that we can use it in emergency, in community, and also in that healthcare gap. Next slide. So I'm going to wrap up in thinking about this, that not only in AI and data, we can help it on number 1, the diagnosis of the patient's problem, but also number 2, to track their treatments and how can AI and ML help that patients as a population to figure out strategies for us to treat. But for N of 1, for that particular patient, what are some of the moments that we need to be aware of to support them, but also not just support them on illness, but support them on encouragement to say, you're on a great road, you're recovering very, very well. But in addition to 1 and 2, it's about number 3. How can we, after 1 or 2 of these episodes, start to help detect illnesses before they happen? And so I think that can help in a lot of prevention. And finally, if we have enough of these cases on that particular patient, we can go to number 4 and start to predict, how can we make sure that this patient stays well, stays in the community, doesn't need hospital, put me as an emergency physician out of work? I think at the end of the day, this is the why of AI for me as a clinician, as an emergency physician, how we can help our patients. My last slide is, I just want to acknowledge that I'm a mouthpiece to a group of people that's working together in these projects. So I want to thank all of them for working together on this. And again, thank you very much for your attention. I look forward to some conversations with you and learn from all of you. Thanks.
Well, if we were in a room, wouldn't that be nice? We'd clap for all of our speakers at this point. But as it is, we can silently clap as we are. The great news is we have a good amount of time now for some Q&A, and I'm going to begin by going to questions that have been entered in the Q&A box, but with a focus on questions that are, really applying to all of the panelists and maybe getting at some of the foundational things here. So I'm going to synthesize a few questions here together and go with one that came from CFHI staff, which is about advice that you'd offer to organizations who are thinking of starting to implement AI. And you might work in some responses to the questions about barriers. Is it tougher to implement something that's AI based as opposed to traditional statistical methods? But also hoping that some of your lessons are, framed in a positive way. If you do this, you're more likely to be successful. Is there anyone who'd volunteer to go first? So we're talking about the question, what advice you'd offer to organizations who are thinking of starting to implement AI?
Well, happy to jump off the discussion because I do recommend this all the time, which is don't reinvent the wheel. Someone has published something about whatever you're planning to do. And so first of all, do a medical literature review. Second is go find out who is actually doing something interesting in that space that is not published yet. So reach out to similar organizations, not just in Canada, but worldwide, who may have worked on something like this. And typically it's presentations that are available on the web or conference posters and other things. And they're more than happy to give you a teach and say, this is what we learned doing this, and this is how we adjusted our project, so you don't have to start at square zero. And last but not least, involve the end users and the people who this will be applicable to from the get-go and regularly. And so clinicians and patients need to be part of this process, not once at one point, what would you like to have, and thank you, goodbye, but an ongoing engagement with them in order to ensure that the good intentions end up with something that's actually useful.
Maybe I'll jump in. Oh, sorry, Dr. Baptist.
I'm sorry. I think that that's all very excellent advice. I'd add 2 specific additional points, and that is, even though you might learn from other centers, there's some particularities to your centers always when it comes to governance, legal aspects, and ethical aspects. And so you may be raring to go only to find that your ethics committee is not raring to go, and that the legal authorities at your institution are very concerned about data sharing and data privacy. And that is a really moving train, and has been moving quite a bit in the context of COVID. Once again, we did a material transfer agreement to build the largest cancer patients who are COVID positive repository in the world over the course of a weekend in late March because of the urgency of it. But we got a feel for multiple cancer centers around North America and in fact, Southern Europe, and the differences in how these things are approached. So before you are raring to go, it's very important to check out those aspects of your environment. And then the other point I would make is that a very big part of a digital health and AI inclusion or introduction of AI into that environment, of course, involves change management. And so, and so you have to understand all of your stakeholders. And I think Alexandra's suggestion of the importance of the patient is very good, because the patients can drive physicians to change their behaviors much better than their bosses can.
Yeah, I completely agree. Those are excellent comments, Dr. Battis and Dr. Greenhill. Maybe I'll just add 2 points onto their excellent items already. Peter Senge talked about health system change. I think there are 3 elements that can lead to system transformation. One is having the right people together to have this conversation together. And I think that comes back to Dr. Papisa's introduction and also the paper on Nature Medicine about the right population or key stakeholders, actors, users. Those are going to be very important. But secondly, it's going to be very important for that group to have conversations so that it can do sense making, so that they can understand which each partner, what are their activities, what are their roles, what are their actors, and how do they bring forward. I think that's where the understanding comes. And then to really do that kind of co-creation piece, that not only look at the best evidence out there, but as Dr. Battis talked about, how do we apply it into our context as we move forward? So I think that's important. And then my second point is that I think we need to put a mirror in front of us. What I mean by that is evaluation and capturing of data right off the bat is going to be so important. When we exercise, some of us exercise in front of a mirror, not because of vanity, but because we want to figure out, do we have the position right? Did we straighten our arms correctly? Did we do the squat well? My daughter always said, you got to squat right or you're going to ruin your back. And so in the same way, I think evaluation is that piece of mirror to help us to say, when we do our PDSA, are we doing it well? Are we continuing on it? And so the evaluation will be as important in the beginning as it is in the middle and at the end in summative and formative evaluation.
Thank you all. Those are great responses, and I do, again, really appreciate the positive framing in terms of what to do. I'm gonna do another sort of twist on one of the questions that came in, and also building on something all speakers presented is this. I was really impressed how many of the examples were about things that would happen outside of acute care settings. And, a lot of the early implementations of AI were in hospitals because there's lots of data and computer vision. Maybe you could just share some thoughts on things that you see promising, in particular, expanding on what you've spoken about, or even new, completely different examples, taking AI into community, potentially into low resource settings. How's that for a question? I see Dr. Greenhill, you're unmuted. Would you like to go first again?
Yeah, that's one of my areas of passion. For the last 30 years, we've known that care actually happens outside of acute, much more so than it happens inside the hospital. And if we do a good job, people don't end up needing emergency rooms and hospitals. One of the ways to get rid of emergency room wait is to make sure that the community services work well. And so what's really exciting about AI and new technologies is that they can literally leapfrog. I was part of a global conversation. I said, well, here you go again, the risk will be a hex in Africa, doing some projects using simple cell phones and text messages, then the developed countries can be.
Great, and I see other nodding heads. Dr. Ho, do you want to weigh in on this?
Yeah, maybe I'll jump in. I think it's a very important question. I guess the question is, it reminds me of a joke about the fact that you find a person looking for keys under a street lamp in a dark day, a dark night, and people said, where did you lose the key? Over there in the dark area. Why did you look here? Because the light is here. I think the issue is this: that in acute care we have lots of data, but it's shining on when the patient is sick. I think what we need to do in the community is shining on the data when the patient is, well, in fact, not patient, when the person is well. And I think that's going to be a huge area for us to actually participate in, etc. And so once we have that community base of wellness and health, then we can put the data in acute care in context, as opposed to the tail wagging the dog. And so I think we are, doing some new things about therapy, treatment, and things. But I think the huge opportunity in community is to measure wellness. And if we have that database and we have the acute care database, we can advance health and management of illnesses so much better.
Dr. Battis, would you like to add to this?
Yes, thank you. I think I could just add to the general themes that are coming across here, and that is that our mission really now is to bring healthcare and wellness care to the patients rather than patients to the institutions. And one of the functions that we talked about, these dynamic, provocative PROs, and the evidence that we have of not having the patient wait till the next appointment, the impact that has on ultimate outcomes is enormous. But I can tell you that I just co-authored a paper that appeared, I think, just this past week in a Canadian Cancer Journal, where we analyzed the front end of lung cancer from symptoms to hitting the door of the hospital. Now we focused on delay times, delay to surgery. Only 25% of lung cancer patients at most go to surgery and benefit from surgery, and delay times in chemotherapy. So those couple of weeks in the institution, if we can accelerate all those things, might have some impact on survival, but nothing near the impact of getting the patient from symptoms to treatment faster, and all that's taking place in the community. And on our paper, we showed that patients who just come to the emergency room end up, of course, they're there, they get there sooner, they might be a little bit more sensitive to their symptoms, or they may be more advanced by the time they come there. But patients who come through the kind of GP network of workup and an antibiotic for trial for a while, and then another X-ray, and then maybe a scan, they take longer. And so what it indicates is we have a lot of work to do, but that's a weak point, but that's where we can fix things, just as Dr. Greenhill suggested. So I think there is a place for AI in accelerating these processes, just by generating the trajectories, doing mapping as all of our projects begin now. So I think we're excited about doing that, and that's a major project for us.
So I'm going to pick up on some of the things that came through in the responses, this idea of engaging with patients' involvement outside of acute care, and even, as you know, Dr. Ho, engagement with members of the public. They're not patients at all. They're well at that point. And this also will bring in one of the questions in the Q&A. Can you tell me about what you're doing on that front, how you're engaging with and hearing from people? And when you do, what do they say? Are they supportive? Are they concerned? Are they conditionally supportive?
Oh, sorry, Alexandra.
Well, let's see if we fix my audio issues. I think it's coming better through the phone. And so the important thing here is both an individual engagement and an overall societal engagement, because the movies keep feeding us, tales of AI gone mad. And those internet jokes, to Dr. Ho's point, sometimes a joke illuminates an anxiety in the society, and it's that sort of you call for pizza and says, sorry, we can't give you double cheese because your cholesterol was high. And so, like, will AI control what I do? And in a negative sort of way. And so the interesting thing in healthcare is that people at the front lines, both patients and physicians and clinicians and nurses and physiotherapists, are much more ready to embrace some of these tools. And they are asking all the right questions, which is important. Like, how was this trained? Did this include people who are like me as part of the algorithms or approaches? And they expect us to proceed with caution so that we automate some parts that sort of make work, or that's human in the loop. And so I've had these conversations with people of all lives of life, and they're curious and engaged. And the thing that they really want us to do is they want better access, better quality, and better safety of care. And if AI is one of the tools that can now help us do a better job on those things, let's do them. And so one of our supercluster projects takes skin cancer diagnosis from an average time in BC of 36 weeks down to a couple of days. And, you know, some melanomas change stage in 36 weeks. And so why would somebody not in downtown Vancouver have worse access than anywhere else in the province? And the only way we can scale our ability to support patients is by using algorithms and predictions and taking a picture of the lesion first and saying, should it be biopsied? Should it be fast tracked to a dermatologist? And of course, monitoring and looking through that. But the usual response from the public is like, yes, we want this. How fast can you bring it into our community? And the same aspects around preventing other types of cancers or heart disease, or telling them which one of the multiple things that they're reading about in terms of health changes will be the ones that are most promising for them. And that's the promise of personalized medicine that Dr. Batiste talked about.
And thank you. Maybe just briefly, Dr. Batiste and Dr. Ho.
Sure, briefly, I would say this is where our reluctance as medical people, scientific people, to talk to the public really is not serving the public well. We should be out there talking to the to the general public and encouraging them to be the change agents. I mean, I think the general community and the patients in the general community are the best pressures of the clinical community to change their practice, to adopt new novelty and to change practice. And so this should be a very positive thing that we are endorsing and pushing in the media.
And your head is nodding, Dr. Ho.
Yeah, three very quick points, how we engage our general public and patients. One is in our research, we certainly have patient partners in our committee. For example, our Tech for Home, it was a patient who said, wow, this is fantastic for surveillance and monitoring, but why don't you call it co-monitoring? We change our complete attitude just on that one comment of many, many excellent comments. Second, we do focus groups, and also we engage the public when we launch our research. And so we need to understand where they come from. And the third is it's a car commercial, you know, drivers want it. You know, the commercial says, you know, if you build the best car, but people don't know how to drive it, it won't serve its function. And so we've been launching digital health literacy so that we engage our general public, show them about what are we doing in electronic health record, healthcare, virtual care, so that patients and public know them, and then they can give meaningful feedback and engagement.
Thank you so much to all our speakers. Christine, I'll go back to you, I think, for closing remarks. Is that right? And to finish things off?
Yes, thanks, Dr. Prisa. Wow, great discussion. I mean, clearly we could have extended the time on this. Lots and lots to share. Thank you, Dr. Prisa, for starting us off, giving us that nice framework to think about as we're discussing, to each and every one of our panelists for some very exciting examples of AI in use, and some really good reminders about, you know, things like the human factor, the importance of equity, and, you know, and I really loved where we rounded things out by, you know, underscoring the importance of engaging with patients and the public. That's what we're here for anyway, right? So thank you again for your presentations, and thank you to all of our participants for your time. We will be circulating today's webinar recording and a summary of the conversations and responses to any of the outstanding questions. So I would ask that participants do take a moment now to offer us some feedback. We need to keep improving and learning, so invite you to fill out the survey and tell us how we can improve on upcoming calls. Thank you, everyone, and have a fantastic day.